Hello, everyone. My name is Lisa Mattisbach, and I am the Path for PWS Study Coordinator. With me today to talk about the issue of hypogonadism in PWS is Dr. Diane Stafford. Dr. Stafford is a clinical professor of pediatrics in the Division of Endocrinology and Diabetes at Stanford University in California. She has been providing care to children and young adults in the PWS population for over 20 years and has a particular interest in disorders of puberty common in those with PWS. So thank you, Dr. Stafford, for joining me today to talk with us about the challenges associated with hypogonadism in the PWS population. As a parent to a teenager with PWS, this topic is particularly timely. I've been asking my son's endocrinologist some of these very questions, so let's begin. First, can you give us an overview of what is hypogonadism and what effect does it have on the body?
So hypogonadism is essentially the inability of the body to make what we call sex steroids, so testosterone for boys and estrogen for girls. If there's a diagram, I think, that we'll put up that shows what's referred to as the hypothalamic pituitary gonadal axis. And what happens is at the normal timing of puberty, the brain starts to send signals from the hypothalamus through the pituitary to the ovary and the testes to make these hormones, to make estrogen in girls and testosterone in boys. In hypogonadism, either the signals from the brain, the hypothalamus or the pituitary are not sent to the ovaries or the testes, or there's an inability of the ovary or the testes to respond to those signals in order to make sex steroids, and therefore those hormones are not made by that individual. In the case of PWS, this can present in a couple of different ways. Children can fail to go through puberty. They can start into puberty but not progress. They can complete puberty but not be able to make appropriate sex steroids after puberty. And so there's a whole spectrum of variation in PWS that I think we all need to be aware of. And the reasons for these variations are unclear, just like many things in PWS, but are still under investigation, specifically looking at what genes in the PWS specific region may be involved in this kind of control.
Very good. So how common is it in the PWS population to have hypogonadism? And are there signs that I should be looking for in my child to know if they possibly have this?
So hypogonadism is actually felt to be very common in both boys and girls with PWS. Estimates, are anywhere from 50% to above that, but certainly at least 50% in studies that have been done. But the data is a little difficult to obtain because we don't really have a sort of centralized way to look at the incidence, and I think many of us think may actually be higher than that. In the newborn period, there can be in girls some very subtle signs that maybe they have a tendency for hypogonadism, which is in girls a very an underdevelopment of the labia majora, but mostly not something that people are aware of. In boys, there's frequently what's referred to as cryptorchidism, or failure of the testes to descend into the right location. That may be related to hypogonadism and to lack of testosterone exposure in utero, in development in order to bring those down. There's also some hypothesis, however, that has more to do with abdominal musculature and pressure and the ability for the testes to descend. But certainly having lack of descended testes in the newborn period should at least put in people's mind that there may be a tendency for development of hypogonadism later on. At puberty, what we're really looking for is lack of development. So breast development normally happens in girls at around 10 years of age. So lack of development at that age, lack of the beginning of breast development as the first sign of puberty can be a sign of hypogonadism. In boys, the first sign of puberty is actually an increase in the size of the testes. Again, not something that most parents would be aware of, but certainly something that a physician can examine for. And lack of that development in boys at about 12 can be a sign that they have either a delay in puberty or potentially a tendency toward hypogonadism. So what we're really looking for is things that are not happening in the normal timing, rather than something that is happening that you might see.
That makes sense. Should every person with PWS be checked for hypogonadism, and what kind of doctor would do this?
So I do believe that every child with PWS should be evaluated for potential hypogonadism, or at least, if not evaluated biochemically, at least examined and followed to determine whether they are progressing into puberty at an appropriate time and at an appropriate pace. So part of it is, as I said, is the timing, and part of it is whether or not they actually continue to progress. This kind of evaluation is typically done by a pediatric endocrinologist. And as these are the people who most commonly are monitoring growth hormone therapy as well, it makes it a little bit easier for children with PWS to be monitored for progression of puberty. So much of the time, they don't need a new doctor. They need an endocrinologist who's already following them for growth hormone therapy, as well as potentially other hormonal deficiencies that can be seen in PWS.
So is there a right time to be asking these questions, and is it different in girls than in boys?
Yeah, I think there is a right time for everything, and this in particular. It is different for boys and for girls. So the time to begin asking these questions is really around the normal time of puberty, which does differ between boys and girls. Girls typically enter puberty earlier than boys, with an average age for the beginning of what we consider puberty, which is the beginning of breast development, at an average of around 10 years of age for girls. And as I said before, for boys, it's a little more difficult for parents to see when the beginning of puberty is, but it is actually the beginning of testicular enlargement, which is a response to the signals from the brain, and response to changes that lead to testosterone production. That's more typically somewhere around 12 years of age for boys. So starting to discuss what's normal, whether puberty is starting, whether it's progressing as expected around these ages would be appropriate. I will say that with all of the other things that are involved in the care of those with PWS, this may not always be a focus of discussion, but it's important to note, both for growth and for overall health for these children in the longer term.
Very good. So if the person with PWS has normal sex hormones pre-puberty or during puberty, does that mean they will continue to have normal levels into adulthood?
So unfortunately, the answer seems to be no. That because of all these variations in timing that I was talking about, you can see people who appear to progress through puberty to an adult body type and all of those things, but who don't continue to make appropriate amounts of testosterone and estrogen. For men, it's harder to see the results of that. So measurement is actually important in trying to determine whether they're still making appropriate amounts of testosterone. They can decrease from where they were before. They can be lower than normal for an adult, even though they might have been appropriate for for a pubertal age group. So you can see sometimes people will report a decrease in exercise tolerance, a decrease in muscle mass, and inability to exercise quite as much as they used to, or build muscle the way that they used to. These are all issues for people with PWS anyway, so sometimes that can be difficult to tease out. For women, irregular periods or lack of periods can occur even if they get to the point of having normal periods initially, and that can indicate a lack of normal estrogen production. So there really is a need for ongoing monitoring for signs and symptoms of hypogonadism, but also potentially for biochemical evidence that there has been a change in the way the body is producing testosterone or estrogen.
So if my loved one with PWS is diagnosed with hypogonadism, what are the treatment options and how do these treatment options differ with age and in boys versus girls?
Yeah, so the mainstay of treatment is really giving back the hormones that the body's not appropriately making. So it's important to think of it as replacement therapy rather than a medication that is changing what the body would normally see. So essentially all we're doing is giving the body back what would normally be there. And I think that distinction is important for people to understand. For girls, this is giving them estrogen. And it can be done in a number of different ways. There are estrogen patches and then there are estrogen pills. The way that we give it differs depending on what age we're talking about and where in the course of puberty someone is. We tend to prefer estrogen patches or what's called transdermal estrogen early in puberty, because we can start with lower doses and increase gradually. And also because there's a difference in the way that oral estrogen is processed by the body versus transdermal estrogen. And so it's felt that for most people, any potential risks to estrogen therapy are lessened by using these transdermal preparations. But the important part of that is that we can actually give back smaller amounts, increasing gradually over time to mimic what the body would normally be doing. Eventually, all girls need both estrogen and a progesterone supplement, which can also be done with patches or pills and in a variety of different ways for their overall health to allow them to occasionally have a period or potentially just balance out the estrogen and progesterone so that they have very few or no periods. So there are many ways to do that. And that really does get into a longer conversation about what is the preference of the family and the child in terms of longer term management. For boys, we replace testosterone that they are not normally making, and that can also be done in a variety of ways. There are intramuscular injections of testosterone, which are initially given monthly, and then generally increasing to twice per month. Those are pretty common for initial therapy. And again, because we can give small doses and gradually increase, both in both boys and girls, that gradual increase promotes better growth in height over time, sort of a better growth spurt, and also is giving back the body testosterone or estrogen in a way that is slow and incremental, which is what the body would normally be doing. Later on, there is also transdermal estrogen as well. And testosterone patch as well. And there are some people who are using subcutaneous testosterone on a more frequent basis, every twice a week or so, which is similar to the way we give growth hormone, and therefore for a lot of families a very comfortable way to provide it. Again, sort of slowly increasing doses for adolescents who we're essentially putting into puberty, doses that are a little bit higher for young adults who seem to no longer be producing what they were before. And I want to add that there's been a lot of hesitancy about hormone therapy because the concerns are always whether or not there's going to be behavioral changes or management of periods in girls, and just when you say puberty to people, they get nervous, understandably. But I want to emphasize that my experience has really been that with careful, slow, and measured management, that I have not seen a lot of issues with behavioral change. I've helped a lot of families through making the choices about frequency of periods or whether a girl is going to have periods at all. Obviously, all of these things are conversations that parents should be having with their providers about therapy, about how it's affecting their children, and trying to reach something that is beneficial for their health, but also not detrimental to their mental health or how they are living their lives.
Dr. Stafford, I want to thank you for this wonderfully informative talk on hypogonadism in PWS and for giving generously of your time and knowledge to help our community better understand this common medical issue. I know that I have learned a lot today, and I'm certain parents will find this information incredibly helpful as they navigate future visits with their endocrinologist. Parents, if you would like to help us learn more about hypogonadism in PWS, I would encourage you to visit the Global PWS Registry at www.pwsregistry.org and complete the endocrinological history survey so the experiences of your loved one with PWS is represented. For questions or help with the registry, please email info@pathforpws.com or call 760-420-5878. Thank you.